Thank you very much, Chairperson. First, I would like to thank the President, Council and the Organizing Committee for giving me this opportunity. I'm not quite sure whether it is the correct time to talk about sugar, but let's see. I'll try to go briefly on my topic. So, sugar is high. Are we treating it right? So, I will talk mainly on two areas. Are we treating diabetes right? And how to treat diabetes right. So, why does diabetes draw much attention? Because if you take the global prevalence, the percentages are quite high. And what about Sri Lankans? We are at a higher risk of having diabetes compared to the other rest of the country. And if you look around yourselves, count the number of people around you. So, usually 1 in 11 among yourselves should be having diabetes, so go home, go to the lab and check, right? Or in our community, it's like that. This is global prevalence in 2015. So in 2040, it'll be 1 in 10 people having diabetes. Is it relevant to Sri Lanka? Well, actually, it's worse. In 2008, our prevalence was 10.3%, and but recently in 2014, urban prevalence had been like 26% of diabetes. So almost like 1/4 having one person among 4 of us will be having diabetes. So it's important, and that's why probably the Ratnapura Clinical Society had invited me to talk about diabetes. So are we treating diabetes right? Am I just talking about global data? No, this is our data. One of my colleagues did in Colombo in 2018, where they have seen the HbA1c of patients with diabetes being 8.4% in females and 8% in males. So are they the desired numbers? Well, not really. So how have that manifested? In 2016, Sri Lanka, macrovascular complications among diabetic patients had been seen in 13% and microvascular in 74% of patients. So that's a quite large number. So have we treated diabetes correctly? If you take these numbers, there's some problem, either ourselves or the patients or somewhere. So that's why we are talking about this. So can we do better in managing diabetes? Well, how to do better? Well, we have to look into the diagnosis and the correct treatment modality. Are we getting the glycemic targets correct? And timely up titration. If the sugars are high, we have to do something to get it down and then manage complications and comorbidities. That's our part, together with the patient. But patient and family education and social supports are as important as the previous ones, which I would not actually talk during the given time. So I'll just talk about how to get the sugars down and get a better control. So managing diabetes is not only high sugars. So although we talk about high sugars in the clinics, it's not so. Why? It is a combination of high sugar levels and diabetes related complications, as well as associated non-communicable diseases like hypertension and dyslipidemia. All these contribute to the quality of life, morbidity and mortality of the patients with diabetes. So if we are to improve these quality of life, morbidity and mortality, what we have to do is to manage the whole set, not only glucose levels, complications as well as NCDs. That's where we go wrong. We only check the sugars. No, it's not so. It's a combination. So I'll just go through the diagnosis part, what we can do better. So all of us know the criteria for diagnosis, where initial 3, HbA1c, fasting blood sugar and OGTT, we need 2 samples, 2 figures to diagnose diabetes, but we have seen treating patients only with 1 report, which would not give the best outcome. So imagine you go to your PP or a relative comes to your home and then shows you a report of fasting blood sugar 140. I would touch the basics because there are some students as well. Are you going to treat or not? What would you say? Go home, get some lifestyle modifications and be happy. You can do it with lifestyle modifications. Well, not so. Like I said, you need to do another test. So then they would ask, which test? When? Tomorrow, day after? So you need to know the exact answer. So it could be any of the above tests which is convenient for the patient. So if one test is abnormal, you may repeat the same test or some other test. Is there a duration? 2 weeks? 1 week? Previously we used to say 2 weeks. Well, it's not so. Any day, even the next day, but unless the patient has any infection or any illness. So the patient comes, your relative comes with another report. It's high, above the cutoff of fasting blood sugars. So yes, we can diagnose diabetes. What about this? Another test. He comes with a different test. Again, above cutoffs, both tests. So it's easy. You diagnose diabetes. What about this? We come across like this a lot. Fasting is high, HbA1c is, well, not diabetic, kind of pre-diabetic level. What to do now? Are you going to write to a VP or an endocrinologist? Well, this is simple. You can manage this. So this is how we treat sugars correctly, right? So you need to repeat again the higher test, whatever the test which is higher. So it's fasting blood sugar or completely different test. You may do a 2-hour OGTT, postprandial blood glucose level. Similarly, vice versa, same scenario, same principle. And you may see the last one, fasting is 116, HbA1c is 6.8, which is in the diabetic range. Then we did OGTT test, which says it is not really diabetic range. So pre-diabetic, you may tell the patient, okay, you are in the queue for getting diabetes, so be careful, do these tests, and that's how you manage diabetes. If this is persistent, you need to think about hemoglobinopathies as well. Okay, just few cases. This is a 42-year-old male with acanthosis and family history and obesity. So what would you think the diagnosis? Because it's important to make a correct diagnosis. So I'll just go through this quickly. Pancreas usually secretes insulin, which will cause the cells to take up glucose. So if we take this as a lock and key principle, key is insulin, lock is the cells. So if there is a problem in the key, if the pancreas does not produce any insulin or keys, that is called type 1 diabetes. If there is a problem in the lock, where the cells are not responsive, the door is not opening for the glucose to go in, that is type 2 diabetes, where there is a resistance in the lock or the cells. So that is the basic difference. But how do we differentiate? In type 1 diabetes, usually they are adolescents, young children, they're lean, they don't have resistance. And in type 2 diabetes, they are obese, eating all the junk food, having acanthosis and has a family history. Why this is important? The treatment is different. Type 1, it's insulin. And type 2, it could be managed with oral medications, plus or minus later insulin. So, number 2 patient, again lean patient, high blood sugars, osmotic symptoms, that is type 1 diabetes. Upper patient, obese patient with acanthosis, type 2 diabetes, which could be managed with oral medications. What about this? Young male, lean, is it type 1? Well, there's no acanthosis here, could be type 1, but there's a very strong family history of diabetes in young. Is it type 2 or type 1? Doesn't match any of these. So these are important things that you need to know, because the treatment is different. And if you treat wrongly, make a wrong diagnosis, the blood sugars or whatever you treat will not come to the target. So if you see young kids or lean adolescents, well, likely type 1, unless there's other features. But having said that, this is a young girl, 13 years I guess, having acanthosis and quite overweight. So that is type 2 diabetes. And the last case I showed, young, again, male, lean, not like type 2, not type 1, because there's a strong family history. We call it MODY or maturity onset diabetes of young, where there's a very strong family history from generation to generation of young onset diabetes. And usually this is treated with sulfonylureas, not the classic metformin. So it's important, if you give metformin, the sugars will not be controlled. So it's important to know the diagnosis correctly. Some interesting case which I come across quite often, again an adult, very lean, and no acanthosis, no family history, he was quite fine, but the sugars are pretty high. We see quite a lot of these patients in Neurelia, and if you really see, this patient doesn't belong to type 2, not type 1 as well really, and no family history, no MODY. So there are pancreatic calcifications, and if you treat this adult with metformin, it's not going to settle the diabetes. So this has to be treated with insulin. So that's how the diabetes diagnosis is important in managing, getting a better control. So if I have a patient newly diagnosed with type 2 diabetes mellitus, I'll concentrate on type 2 because it's more prevalent. How should I proceed? Just, it's easy, isn't it? Metformin, then sulfonylureas, then DPP-4s, sitagliptin. So people think it's just the same prescription. It's not so. It should be individualized, and it depends on your HbA1c and fasting blood sugars. If the HbA1c is less than 9 and fasting blood sugars are less than 300, no asthmatic symptoms, well, you can give lifestyle modifications plus monotherapy, or if it is slightly higher, you may give dual therapy, that is 2 drugs. Some people, now we tend to tell, okay, tikak sugar වැඩි කෑමෙන් පරිස්සම් වෙලා බලමු. Well, that's not the case, right? This is always lifestyle modification plus medications. And if the sugars are quite high, more than 9% HbA1c and fasting more than 300 milligrams per deciliter with asthmatic symptoms, the ideal treatment is insulin initially. You may switch to orals when the sugar levels are fine. Why am I stressing that you need to treat initially, not the lifestyle alone? If you see this, blue line, the lower line shows intensive treatment, like I said. The purple line shows 6-year delay in routine care, not taken treatment for 6 years. So if you see the cumulative incidences of cardiovascular events, the patients who had not taken treatment has higher cardiovascular events. So it's very important, if you diagnose a patient, early blood glucose control reduces micro and macrovascular complications. Okay, now I'll go through 3 clinical scenarios so that we know how to manage diabetes properly. So this is a 46-year-old. Now I'm switching gears from diagnosis to management. Case 1, 46-year-old, otherwise healthy lady with diabetes for type 2 diabetes for 1 year. Sugars, fasting sugars we always do, that's 132. Not bad, we are happy. Well, she comes up with another test with HbA1c of 8.5. Well, are we okay with HbA1c of 8.5? She's only on metformin. Well, you may say 8.5, not 10, that's fine. But you have to decide, this patient should have this HbA1c and this patient should have this HbA1c. How do you decide? Now, HbA1c of 8.5, if you see roughly here, it indicates an average glucose of 180 to 250 in between. So this patient, although fasting says 132, she had been running at a higher sugar levels. So what is her target? So if the patient is young, otherwise healthy, target HbA1c should be 6.5 to 7, whereas elderly with comorbidities, 8%. And the usual numbers that we go through fasting and PPBS are tighter control in young, healthy, elderly with comorbidities, less tight control. So in this patient, I would take somewhere around 7% of a target blood glucose level of HbA1c. Why is it important? Higher the HbA1c, you can see 10% or 11% HbA1c is having higher complications compared to lower HbA1cs of 6 to 7%. So it's important to have tight blood glucose control to reduce micro and macrovascular complications. Okay, we know the target now, how to achieve it. Now this is where the guidance comes. It's not metformin and second line glycoside. No, that's not so. Second line depends on the comorbidities. If the patient has ischemic heart disease, heart failure or renal disease, it is not the second glycoside or any other medications. It's the newer anti-diabetic medications like SGLT2 inhibitors or GLP-1 agonists, which are available in Sri Lanka also, but in the private sector. But both are in private sector. Yet, if the patient can afford, this will have more mortality and morbidity benefit over the other drugs. So if your patient does not have all these, well and good, you can go with any of the other available medications. So remember, it's not always the routine drugs which we should give. Okay, now we can likewise, fine, now we know how to achieve it, you go with other medications. Like I said, it's important to check for other NCDs. You have to control hypertension, control dyslipidemia, and improve weight and stop smoking. And in these patients, it's important to look into the macro and microvascular complications. And how do? We check annual screening with renal, cardiac, and then also foot screening and also retinopathy screening. So when we do this is comprehensive care. And a regular follow-up and monitoring should be aimed at with all what I said. Okay, now that is 1 year duration of diabetes. Case 2 is this patient having diabetes for 12 years and then sugars, fasting sugar is 198 with HbA1c of 10.3 on our routine medications. What's happening? Well, this is the natural history of diabetes. It's very important for you to know because sometimes we go quite wrong on these. So when we diagnose diabetes, let's say 0 time, year of diagnosis, 50% of our beta cell mass is gone. Patient has lost 50% of the mass. So you have only 50% for the rest of your life. And then you start with one medication. Well, when the insulin levels go down in the body naturally, you increase the medications to 2 medications, then 3 medications, maybe 4 medications. But there will be a time where the insulin level in the body will be very low. These medications can't function alone without the basal insulin levels in this patient, although the patient is type 2. This is not a type 1 patient. So in that case, it is important to start insulin. It's not like all the myths that we have about insulin. It is a requirement to start insulin. People may say, okay, can I have another oral medication? It's not so. This is the pathology, you treat the pathology. So for that, the treatment options are mainly insulin, but a newer class SGLT2 inhibitor drug can give some time without starting insulin in suitable patients. So I hope you know about SGLT2 inhibitors. They are called empagliflozin, dapagliflozin, canagliflozin, very exciting drugs. What they do is, now usually our glucose is filtered and almost 99% is reabsorbed from the renal tubule. These drugs block this. So all the filtered glucose will be passed through urine. So your urine will be very sugary, but the blood glucose will be controlled. This drug has very good mortality and morbidity benefits, cardio safe and renal safe. Now the cardiologists use this drug even for patients without diabetes, so as nephrologists. So if you see, this drug works more with patients who have higher HbA1cs than the low HbA1cs. That is because of the mechanism of action. Problem is, having high sugar levels in urine will prone you for urine infections. So you have to instruct the patient. Okay, case 3. So you need to start insulin or SGLT2 in our patient who had poor control with 3 medications. That's the conclusion of last case. So case 3 is 52-year-old male, again coming with high HbA1c. We can't use SGLT2 insulin 2 inhibitors because this patient has history of recurrent UTI. So then what? On loads of other medications, and then that's the place for insulin. You need to start insulin. There is always a delay in starting insulin because this is data from abroad. By the time they start insulin, the HbA1cs have been all above 9%, which should not be. When it goes beyond 8 and if you can't control, you should be starting. Why insulin is so good? Because insulin causes the highest HbA1c reduction compared to all the other oral medications. And now this is an interesting graph. This is addition of other medications. For 2 oral medications, one oral medication added another one, it reduces HbA1c. Third one, well, there is some reduction, but it's not so. Fourth addition of oral drugs, it won't cause much of reduction in HbA1c if you can take the yellow line. But if you add insulin to the current regime, there is significant reduction in the HbA1c. So adding drugs alone will not cause much of improvement apart from insulin. But the problem with insulin is us as well as patients, there are so many problems, clinical inertia to start insulin. Okay, last few slides. So it's important to up-titrate the medications depending on your glucose levels. So this patient comes to you and says, my fasting blood sugar is 108, I have good control of diabetes. Yes, we also agree, fine, because our targets are like this. Are we happy? So having a fasting blood sugar of normal does not mean that your sugars are fine, because A, B, C patients have different sugar profiles during the day. But the fasting is fine. So fasting alone will not give you the best indication of diabetes control. Number 2 is, I have diabetes for 3 years, my fasting blood sugar is 101, PPBS is 268. Is it correct? So this patient has poor glycemic control. Am I going to increase the medications? Well, please do check the PPBS. This is very commonly happening in clinics. These patients do not take their routine medications before the postprandial blood glucose test. So if that happens, sugar levels will be very high. But if the patient had taken drugs and done the PPBS, sugars would have been controlled. So do not increase the drugs, because patient will admit with hypoglycemia. Just check, just ask, right? And repeat. Okay. And now this is important. Fasting good, postprandial good, I have very good control, I'm happy. So it's on target. But, and what about HbA1c? HbA1c is 11%. How can you explain this? Well, I ask these patients to do a SMBG, self-monitoring of blood glucose. HbA1c gives the mean. But if you see the glucose profiles, it's up and down. So it's important in these kind of patients, if there is not tallying, you need to check the film rather than a photo. So you need to understand the story during the day and not only a single value of blood glucose levels. So that's what we do in Sri Lanka. But abroad, there are technologies in diabetes, continuous glucose monitoring, where there's a device implanted in subcut tissues, and you see this kind of pattern. So you see the whole eating ice cream and this and that, hypos, everything. And in couple of years, several years, patients will be coming to you saying, doctor, my time in TIR report is 50%. Are you happy? So this is the future. So we check the time in range. We categorize patients, okay, your range is this, your range is this, your range is this. And then we check the time in range, the percentage time that the patient is in range. And depending on that, we will be altering the medications, not depending on HbA1c. And there are so many insulin delivery mechanisms, islet cell transplants and insulin pumps in pipeline in Sri Lanka, but already available abroad. But having said that, not only medications, monitoring, regular exercise and dietary control is as important as medications. So I wind up saying this, and it's just a summary, and thank you very much. This is all photos from where I work, Nuwara. Thank you.
Okay, thank you, Sonali. I think we can entertain maybe one or two questions if time permits. May I ask a question, Sonali?
Yeah.
Now, one of the things we see in the wards, medical wards, is hypoglycemics. More elderly with multiple comorbidities coming with hypoglycemia. So you mentioned that the target should be around 8. I think we need to highlight to the medical officers that the target should be.
Yes, it's very important. A lot of elderly patients or even young patients with multiple comorbidities like heart failure, many other things, do present with hypoglycemia, because one reason is, like I said, the postprandial blood sugar levels. We are not paying just 1 minute to ask. or we are not going with the target. So be less stringent on those who have less life expectancy, having a lot of comorbidities. On top of several comorbidities, they don't want another episode of hypoglycemia or life-threatening hypoglycemia scaring them, and we don't want that happening. So be little less stringent. It doesn't mean that you can be like happy with 300 milligrams of deciliter blood sugar levels, but you need to optimize, and importantly, you should avoid the fluctuations in these patients. There are a lot of fluctuations, so it's very important to get the blood glucose monitoring by these patients if possible, and that actually reduces the morbidity and mortality. If you take a 7% HbA1c in that kind of a patient, that will increase the mortality and morbidity.
One more question, Sonali. Just because there are a lot of medical officers as well as the medical students there, usually in the clinic, though the patients are on insulin, they just look at the fasting blood sugar and they just adjust the insulin dose. So what is the message that you want to give to the medical officers who are mainly looking after seeing a lot of patients in the clinic, and how to control the blood sugar properly?
Yeah, so like in the last slides I showed, patients on insulin, it's so the sugar levels are so fluctuant. If you check one day fasting, it would be 70, next day 200. That's purely because the sugar content of the meals that they are taking the previous day likewise. So it's important, my advice is, don't go with fasting and PPBS just one report. If you have doubts in controlling these patients, do a profile or see the pattern. Do fasting blood sugars on several days, and maybe PPBS or pre-meal test in several days, and go for the pattern. Even in ward, don't just change insulin for one reading of slightly high sugar levels. Go for the pattern. If several days the sugars are high, you may increase. If there is fluctuating cause, you need to check more in this patient and identify the pattern. Treat the pattern, not just one value.
Thank you, Sonali. That is the exact answer actually I wanted, because that's a very common thing happening in our day-to-day practice. And
Thank you.
thank you. And then I would like